All right, it's 3 p.m. In the interest of time and our lovely schedule, let's go ahead and get things started. Good afternoon, everybody. Welcome to session 4 of the Million Hearts Learning Lab, Optimizing Care for High-Risk Patients with LDL over 190, Messaging and Management. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NACC, and I'm pleased to bring you this event along with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. Next slide. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 45 minutes, including introductions, very brief presentations, and Q&A. Again, the duration of this live event is approximately 45 minutes. Throughout today's session, we'd love for you to use the Q&A box located in the lower right-hand side of your computer screen to ask your comments, questions, or concerns. Simply open up that panel box, and if it is closed for you, just simply click on that little bubble and it will expand for you. Type your comments, questions, or concerns, and make sure you hit that send button. That's super, super important for us to receive your questions. Friendly reminders that today's event is being recorded and will be made available after this event has been completed, and all attendee lines have been muted. At this moment, I'm going to turn things over to Meg, who will be setting the stage and taking it from here. Meg, the floor is yours.
Thank you so much, Liz. So welcome everyone to our 4th Million Hearts Learning Lab on optimizing care for high-risk patients with very high LDL, with a particular focus on messaging and management. I'm Meg Metter. I'm Director of Clinical Integration and Education with the National Association of Community Health Centers, and I'll be moderating today's session. So I want to just start with talking a little bit about Million Hearts. So Million Hearts 2027 is a national initiative that aims to prevent 1 million heart attacks, strokes, and other cardiovascular events over the next 5 years. It's co-led by the Centers for Disease Control and Prevention and the Centers for Medicare and Medicaid Services. And Million Hearts is actually carried out by organizations like mine, NACC. Million Hearts focuses on building healthy communities, optimizing care, and focusing on health equity. If you're unfamiliar with Million Hearts, I encourage you to go to the Million Hearts website, which we'll be putting into the chat, to learn more. Today's Learning Lab is going to focus on cholesterol management. Improving cholesterol, as you can see circled here, is a very important strategy to optimizing care and achieving those 1 million events prevented. The total time for today's session is 60 minutes, but it's packaged into 3 pieces. So we have a pre-work audio recording, a pre-work survey to gather your questions, and then of course today's live event. We hope you had a chance to listen to the pre-work audio recording. This is an excellent short podcast that can actually be used for training your clinicians or staff well after today's event. So I encourage you to access it and share it widely. Our live event today will be 45 minutes, and we'll be sharing at the end how you can apply for CME credits. These are the learning objectives for today's session. So we're going to be reviewing and clarifying recommendations in the 2018 cholesterol guidelines related to optimal statin use, but especially for people with LDL greater than or equal to 190 milligrams per deciliter. We're also going to be discussing the important role clinicians and care teams have in supporting statin initiation for high-risk patients. And then finally, we want to address clinician misperceptions and barriers regarding cost and inconvenience of statins. So I'm honored and super excited to introduce our stellar faculty for today's session. Dr. Larry Sperling is Executive Director of the Million Hearts Initiative for CDC and CMS. He's the founder and was the director of the Heart Disease Prevention Center at Emory Healthcare. He's currently the Katz Professor in Preventive Cardiology at the Emory University School of Medicine and Professor of Global Health in the Rollins School of Public Health. He served as the president of the American Society for Preventive Cardiology from 2014 to 2016, served on the writing committee of the 2018 ACC-AHA guideline on the management of blood cholesterol, and served as chair of the World Heart Federation writing group on the roadmap for cardiovascular disease prevention among people living with diabetes. Joining Dr. Sperling is Dr. Grace Wong. Dr. Wong is a family physician and a senior fellow for public health integration and innovation at the National Association of Community Health Centers. Dr. Wong graduated from the University of Michigan with a degree in early childhood education. She received her medical training at Cornell University Medical College in New York City and has her master's degree of public health also from University of Michigan. Dr. Wong has worked in federally qualified health centers and public health departments in both New York City and Seattle. And with that, I'd like to turn it over to Dr. Sperling and Dr. Wong.
Wonderful. Well, first of all, so great to be with all of you today for this learning lab. Dr. Wong and I are here to address some of the important questions you have, and above and beyond that is making sure that high-risk patients end up with the appropriate strategy for cardiovascular disease prevention. I know in the pre-work audio recording, we touched upon many important topics, and I hope you'll all have a chance to review that. But two of the areas that we haven't fully focused on that we'd like to touch upon today include a review of the 2018 cholesterol guidelines, of which I was one of the members of the writing committee, and then also just our current circumstances, our real life challenges in the midst of the pandemic as it relates to gaps in care, but also opportunities with potential for telehealth and telemedicine and new care models and team-based care. And so we'd really like to highlight that today during our case presentation, and then a review of the 2018 cholesterol guidelines. Next slide, if you would, please. So moving into the 2018 cholesterol guidelines, evidence-based guidelines are a starting point for each and every patient in terms of applying those evidence to our individual patients, each and every one that we see in the office or in other care situations. If you would, next slide, please. We started the 2018 cholesterol guidelines, so if you haven't had a chance to read all 121 pages, there's a brief summary on the American College of Cardiology website, but we started the guidelines with the 10 top take-home messages. And so top take-home message number 4 is that in patients with severe primary hypercholesterolemia, the population we're covering today, with an LDL cholesterol above 190 milligrams per deciliter, after you've excluded secondary causes for high cholesterol, you should have a patient-clinician risk discussion about the importance of starting a high-intensity statin without calculating their 10-year ASCVD risk. Next slide, if you would. This is directly from the guidelines. So the guidelines are with severe hypercholesterolemia, LDLs above 190 in patients 20 to 75 with an LDL above 190 or higher. You want to think about a maximally tolerated statin therapy as the initial therapy for that patient with a class of recommendation at 1. And then in patients who are 20 to 75 with an LDL above 190 or higher who achieve less than a 50% reduction of LDL with a maximally tolerated statin, or an LDL above 100, to think about additional non-statin therapies. An important point here is that we should focus on the appropriate intensity of the statin and LDL reduction, which we'd expect about a 50% on maximally tolerated statin. Next slide, if you would. This is a busy slide, and so I'm just going to call your attention to the right upper corner of this slide, because this is a slide that guides you through ASCVD risk estimation in primary prevention, and then connecting that risk estimation to considerations for both lifestyle, behavioral, and pharmacotherapy. But if you look at the right upper corner of this slide, at the very top, it says LDL above 190. No risk estimation is needed, and start a high-intensity statin. And so even if you have a young, otherwise healthy individual, we'll talk about the importance of identifying likely familial hypercholesterolemia. F plus H equals FH, a family history of early heart disease, a family history of high cholesterol, plus a high cholesterol in that individual should trigger a conversation and the start of longitudinal preventive care. Next slide, if you would. We should focus not only on that thread of a conversation and developing trust and answering our patients' questions, concerns related to their treatment plan. And we'll talk during our Q&A a lot about how do we begin that conversation related to starting a high-intensity statin. But we also want to monitor LDL response. And so we do want to focus on adherence and reassess lipids. Usually I say 2 to 3 months after statin initiation. And if a patient comes back and you see their labs, or you're in a telemedicine visit and you review their labs, and let's just say the LDL is much higher than expected, in a very non-judgmental way, you can ask, first of all, have you been taking your medicines regularly? And then how many times a week or month do you miss taking your cholesterol medicines? And I'll tell you, if you ask that question, you'll sometimes get some really interesting answers that you can address related to patient care. Next slide. We do want to focus for every medication we start on the indications, what would be the potential benefits, but also the risks and side effects. So that's that clinician-patient risk discussion. And we do want to emphasize that statins are medications that not only reduce the production of cholesterol, upregulate LDL receptors as a secondary benefit, but statins not only lower cholesterol, but an important part of this conversation are this is a medicine to reduce your risk of a heart attack, stroke, a need for a bypass surgery, a stent, or dying early of heart disease. So in this discussion, which is a class of recommendation for each and every patient, we should have this ongoing clinician-patient risk discussion. We also want to talk to our patients about their concerns, their questions. And then we do want to recognize that statin-associated muscle symptoms are real, but they are relatively uncommon. And so we want to address questions about these potential symptoms or side effects, but they typically are bilateral, large muscles. You feel like you have the flu, but you don't. And it's not that, ouch, my shoulder hurts, it's from the statin. If your shoulder hurts, it's probably there's some other reason that your shoulder hurts, and we need to figure that out as well. Next slide, if you would. Also from the guidelines directly, coenzyme Q10 is not recommended. So that's a class 3 for routine use in patients treated with statins or for the treatment of statin-associated muscle symptoms. And a really important one is in patients treated with statins, the routine measurements of CPK or CK and transaminase levels are not recommended and are not useful. So you don't have to get hung up on the need for repeat liver enzymes, etc. And if you have labs on the chart from the last visit or the year before and you suspect FH, that conversation can start without repeating labs. Next slide. Just to point out to you that the 2018 cholesterol guidelines, they were the very first guidelines to add 3 recommendations related to implementation science. And that's what our Preventing Heart Attacks and Strokes initiative related to Million Hearts is all about. It's all about implementation. It's going beyond the knowledge, going beyond the guidelines, moving into the care of patients. And really, we have proven and effective strategies for heart disease and stroke prevention. And so I'm just pointing out to you here that we need to use team-based care. We need to focus on adherence and then moving the bar of what's called therapeutic inertia. So we need to cross that threshold and get started with our patients. And then we do want to have that patient-clinician risk discussion. If you go to the next slide, please. There have been multiple impacts of this pandemic. I had my clinic here today, the primary impacts of the pandemic itself, but then unintended consequences, secondary consequences, the impact on chronic care, many patients not having their cholesterol measured for a year or several years, not seeing a clinician for a year or several years. And so we need to recognize that there's never been a more important time for the work that we do related to heart disease prevention. Next slide, if you would. So maybe I'll hand off to Dr. Wong here for the case study, and we'll talk through this and make sure we have a chance to talk a little bit about this very real world type of case that you all might see in your clinics.
Grace, I think you're on mute.
Sorry about that. So this is a 29-year-old female. Because of the pandemic, she was not seen for 2 years. And you finally are able to connect today because you have telemedicine capabilities. And when you look at her labs, you see that her total cholesterol is 290 and her LDL is 225. Her family history is notable for premature ASCVD. Her dad had an MI at a very young age, 38, and also on her dad's side, her grandma had a cabbage at age 48, and her dad and her brother are both taking medication to lower their cholesterol. She's had previous labs that are normal for thyroid, renal function, and liver function. She's an otherwise healthy person in terms of her diet. Her weight is normal, and she tells you she exercises regularly. So Larry, what are your thoughts on this young woman with an elevated LDL of 225?
Yeah, thanks, Grace. You know, I saw a patient just like this in clinic today. And so being young by itself is not a contraindication to thinking about pharmacotherapy. And clearly being young is not a contraindication to having an important conversation with this patient about their lifetime risk, their longitudinal risk. And so even though she's otherwise healthy, she gave us some really important clues, what I would call some red flags that we need to recognize. And those red flags are that F plus H is that she's got a likelihood of familial hypercholesterolemia, a genetic cholesterol problem. And so I think the first part of this discussion is bringing this forward, that just like your family members or some of your family members, it's likely you have a genetic cholesterol problem. And so we want to take the very best care of you, but also extend our care to your family members. And so if you have children, they should be talking to their pediatricians about getting their cholesterol levels measured, because FH, the classic FH, is autosomal dominant. And so if somebody has 2 children, it's likely that one will have the gene for FH. And the earlier we have this conversation and the earlier we begin the combination, the key is combination of lifestyle, behavioral, and pharmacotherapy, we will change the trajectory of this individual's likelihood of going on to have heart and blood vessel disease. And so it is not too early to start a statin. We should have that clinician-patient risk discussion. I had this patient just today who said, you know, what if I became a vegetarian and exercised every day? And I said, I wish that would fix this problem, but our cholesterol comes from many different parts of our physiology, and we make cholesterol in our body, we recirculate it. And so the lifestyle and behavioral approaches are not going to be enough alone to prevent you from having a heart problem. And so look at this statin that we're going to talk about starting together that can help prevent a heart attack and stroke and early heart disease as a way to negate your family history. It is safe starting a statin in a young woman, you know, and talk to her about, you know, potential planned pregnancies. You know, beyond the scope of our conversation today is actually the FDA changed their warning on statins in pregnancy, saying that if you have a very high-risk patient who is pregnant, that it would still be reasonable to continue a statin through pregnancy. But, you know, if a patient's thinking about a planned pregnancy, in the past, I would often stop the statin in preparation, resume it after breastfeeding. And but we want this very young, healthy woman to stay a healthy individual, free from heart disease across her entire life.
A question that sometimes comes up is, how long do I have to be on this medicine?
Yeah. So Grace, I always say, first of all, I say that our job as a clinician is never to convince people to take medicines. This is a team decision. I always say you get more votes than me. But I am here as your physician or clinician, and I'm here to provide you with what I think is the evidence and the guidelines and what I think would be really in the best interest of, I'm a cardiologist, so I always say keeping you away from me and my colleagues in ways that you don't want to encounter your cardiologist. Um, as far as, do you need to take this for the rest of your life? This is a decision we can make together at any point in time. Of course, science will change, approaches will change over time, and at any point in time, if your priorities change, or I always say we sign a contract to 100, but we renew 1 year at a time. When I always say, half kiddingly, when you get to 100, if you want to stop the statin, then we've had a very successful journey together. But don't reinforce that this is a lifelong medicine and you're going to be in chains and chains and shackles taking a medicine. Always play up the positive. The positive is, this is one pill a day that is safe, it's effective, and don't look at this as that you have, you've given in to a medicine. Actually, this is a medication that will help over the many years. The longer you take it, actually, we see cumulative benefit of statins over time. It's the only one thing I remember from calculus is, the integral area under a curve. And so the sooner we get started, the area under the curve is attenuated, and that's a good thing.
Thanks.
So thank you so much, Larry and Grace. And I wanted to just share a comment that came in through the Q&A that basically says, what about answering, let's plan for 10 years and then revisit what the evidence is showing at that time. So that might be a great way to frame that conversation.
Yeah, I think a great comment. Thank you.
So I want to move to Grace, and I'm going to share some of the questions that we received in the pre-work survey, really excellent questions. And so we had several, Grace, that were focused on patient education. And I know that there's a link that you would like me to share, so I'm going to try to do that at this time. But my question is, do you have any advice to share about educating patients?
Sure. Thanks for sharing those questions with me. Some of the specifics were, how to educate patients so they understand the risks of having an elevated LDL. And, this gets to having conversations about the heart. And I asked Meg to help show these images of the heart. Because I don't know if you could flip to some of the others. The heart actually has huge cultural significance and how people think about their heart can also change. And so I think it's really important to sort of keep that in mind as you're having a discussion about why it's important to care for your heart and why we're concerned about having an LDL of 190 over above. Keep in mind that many of our patients who might not speak English can't benefit from some of the resources that you'll see listed in the resources slide at the end of this presentation. And some good resources for that are many times in our communities where English is not the first language, we've in healthcare facilities, we've developed those. So if you have any colleagues who do that work, that might be a good resource. I talked to Meg a little bit about that, and she says there are resources at NACHC that we could help you with that. And I would also encourage you to, if you're in an environment where you have interpreters or other people who help you navigate across different cultures and languages, so ask your team members for some of their insights into when we're talking about the heart and keeping yourself healthy, what are some other cultural concepts that we need to keep in mind. And finally, I think at the end of the day, what we need to do is, if we can, take the time and try to figure out where our patient is. And that's where we start. even though we'd like for it to be some different point in the future. I hope that makes sense.
It does. Thank you. I'm going to go back to the slide presentation. Okay, so really helpful. And I'm going to move on to Larry for the second question here. So this is really a group of questions that we collated together. Several people mentioned patients who didn't want to take a statin or who wanted to try an alternative to a statin. How do you have a conversation with a patient who is resistant to starting a statin?
Yeah, so Meg, thank you. This is a question I'm sure you all are getting very frequently because unfortunately, the lead story out there in the general public about statins are that statins cause problems instead of statins save lives. So always lead with the conversation that I mentioned. Talk about the patient's risk, having an LDL above 190. And although they're healthy at this time, we want to continue what we would call the health course, or focusing on the health span as opposed to the lifespan. As far as this statin, reluctance or resistance, I frequently will begin the conversation about trying to start a medicine in addition to focusing on a healthy lifestyle and behavioral approach. And I think it's really important to watch the patient's reaction, honestly, whether it's in person or telehealth or telemedicine. That's part of what we need to do is look at their nonverbals, and if they're kind of shifting around a little bit or looking defensive, recognize that and say, first of all, this is not an emergent decision today. We don't absolutely need to make this decision right at this time. But frequently what I'll do is I'll write down, if we were going to start a statin, this is the medicine I would recommend at the following dose. And I'll give it to them and say, if you want to think about it and read about it a little bit, just send me a message between now and your follow-up. And if you want to get started on the medication, we'll get it prescribed for you. And I can't tell you how many times a week later, several weeks later, a month later, that patient contacts us after they've thought it through, because in a 15-minute visit, that's a really important conversation to have, and we don't want to have a patient feel like they're being convinced to start a medication. The other comment I frequently provide is that I'll say there's depends on their age and comorbidities, but there's a 1 to several chance of developing muscle aches, pains, and weakness. If you did develop these and they're on both sides of your body, you feel like you have the flu, but you don't, just stop it and let me know. And it's typically finding the right statin for the right patient. I will say there's good scientific evidence, what are called randomized crossover trials, that even in patients that have concerns about statin-associated muscle symptoms, the majority of them will be able to tolerate at least one or more statins. So I'm very reassuring about that we're going to find the right medicine for you. And we don't want you to have any side effects, but we also don't want you to have a preventable cardiovascular event.
Larry, really appreciate that. Yes, definitely. We received quite a few questions also about those side effects. A couple more comments I wanted to share that came in. So one of them was, I tell people it is easier to clean as you go than wait for there to be a lot of mess built up in there. So I thought that was interesting. And then also for preventing ASCVD, would it be true to tell a patient, if you want to pick a 20-year period to take this medicine, age 30 to 50 is probably more important than 50 to 70? So
I think both of those suggestions are right on track. And whoever made, both of them are fantastic. That one about it's probably more important to take it on the front end of life than the back end, that's sagely advice in terms of, and when you get to age 50, let's reassess there. But yeah, it's that early part of life when a silent disease, atherosclerosis, is building up to, unfortunately, for many people that they're unaware of. And so great advice.
Super. So I'm going to shift to Dr. Wong. Grace, we have health centers that are very concerned about costs. So what have health centers, in your experience, done to help patients with the cost of statins?
That's a great question, Meg. Few things. One is to try to figure out if within your electronic health record system, you could have an easy way to identify what's in the formulary for the specific coverage the patient has, if the patient is able to have coverage. And sometimes working with your health center control network, if you have one, can also help with that work. Some other strategies, health centers are very fortunate in that we're able to participate in the 340B program, which enables us to get medications at lower cost, either for our on-site pharmacies if we have them, or if you are able to access that through a contractual relationship with a pharmacy if you don't have an on-site pharmacy. Some of the retailers have their medication prices publicly available. So some of these are like the bigger companies like Walmart or Kroger's, and that might also be a way to help your patients with the cost of medication. And then there are also these things that when I was in the clinic, I used to get in the mail. They were like these GoodRx coupons, which I think might also be another way to help out. And I also understand that our colleagues at CDC are actually trying to work at this at a national level, trying to make sure that there's more transparency and clarity on what are the medications that are available and how to do it at a lower cost.
Absolutely. Thank you, Grace. I have a question now that's actually for both of you. So we could start with you, Grace, and then we'll move to Larry. One of the top barriers to statin prescribing shared by those who responded to our pre-survey was a lack of time in a visit. And so I think, particularly with the disruptions we received or had experienced during COVID and patients coming back into care and having to sort of address multiple things during a visit, how can providers ensure that they talk about starting a statin with a patient during an encounter?
So I think Larry helped us with part of the answer to that question first and foremost, at least try to start the conversation. It may take more than one visit. And what I would find useful, depending on the kind of electronic health record you use, I was in a practice where we used Epic, and I could put notes into myself, sort of where the status of that conversation was, so that the next time I saw the patient or the next interaction, it would be clear sort of where things were if the patient hadn't started the medication yet. The other thing is we are often fortunate to work on teams where we have other folks who help us with taking care of our patients. And some of those tools that we have are, one of the things I used to do is at the beginning of every day that I was scheduled to see patients, I would take about 15 to 20 minutes with the medical assistant that I was working with for the day, and we would huddle on all of our patients that we would be seeing for the day. And if you've put that an elevated LDL is in the problem list, then you know that that's one of those issues that needs to be addressed, and that can sort of help you tee up your your side of the agenda. Of course, it's always a two-way street for what you'd like to cover during that day. And then the other thing, and you'll notice I have some experience working with interpreters. And what I often found useful was if I knew that I was probably going to have to do a little bit of motivational interviewing, or I was going to I would try to tee that up with the interpreter ahead of time, because some of the words that we use in English don't always translate directly, and we'd want to be clear on the intent of the words that we're using and what we're trying to accomplish, and helping the interpreter understand that ahead of time is also useful. The other thing to think about is how other team members can help you when the patient isn't there for a visit. So, if you have pharmacists on your team and they're helping you with refills and things like that, Very often they're going into the chart to look at labs and they'll see the problem list, and they can also help in the messaging on that. And we also, of course, want to be sure that everybody on the team is on board with the same messaging.
Grace, thank you. I just want to call out a comment that was made here in the Q&A, and it says, I just want to share that there's a free app available in app stores that confirm preferred medications for specific insurances. You can search a medication under the insurance and it will tell if it is preferred or not. So that's an interesting idea to explore. I've not heard of that. The app is called Coverage Search. So I just wanted to call that out. Larry, would love to pose the same question to you. I know you did answer it a little bit, but if you have anything to add about how providers can ensure that they at least start that conversation in the context of a visit when they know that maybe that's their only opportunity to see that patient for some time.
Yeah, I think Grace hit some really critically important points. And as I was jotting down some notes for myself, she really encapsulated what I think are the key elements. First of all, get the conversation started. And that conversation is going to be a continued thread of care for that patient throughout the time you and that patient are a team together. Grace mentioned the importance of the team, and absolutely use your whole team. And then I think the other one is, first of all, healthcare doesn't occur in these episodic 15-minute visits. Healthcare occurs over time. So recognize that. Don't put the pressure on yourself. And those conversations in the future, we may get them started in the clinic. And this is where we have the potential opportunities of telehealth and telemedicine. And those conversations may continue either through the patient portal or through a telemedicine follow-up, or with a PharmD or one of our nurse practitioners or nurses from the office. So I think the key is get started and then realize don't let time be your enemy. Let time actually be part of what you see as this longitudinal care plan.
Really appreciate it. And it just reinforces how important it is to document the conversation that you started so that the rest of the care team can see that and pick up, where you possibly left off. So everybody's on the same page. I think that sounds like a really important step. I do want to pose another question to you, Larry, and that's about labs. So I know you mentioned this in your introduction, but I think this is such an important barrier that surfaced during our Million Hearts project. What do we know about the need for labs prior to prescribing a statin?
Yeah, I think similar to time, we make time a barrier, but we also make this need for more labs a barrier. And so if this is a patient that's been seen in the clinic before, and I frequently will just pull up, I've got my computer next to me right here that I used in clinic. I'll pull up all the labs that have been done in our whole system. And I'm seeing a patient for the first time and I'm saying, oh my goodness, this person's had LDLs above 190 for 2 years or 5 years or even 10 years sometimes, because these patients are often hiding in plain sight. We miss them because they look good, they look healthy. They may not have other medical problems. So I don't need to repeat their cholesterol test to show that your cholesterol is still high. I also don't need to, if there's some baseline labs that have been done a year before and they have normal transaminases, normal renal function, normal thyroid function, they don't have secondary causes of hypercholesterolemia. So I would say, get that conversation started without the need for repeat labs. And the only labs that you will need in that person is setting up some labs to focus on appropriate LDL reduction, that percent LDL reduction that you would expect once you've started the statin.
Super. And I'm going to pose one final question here. I think we have time for that. And I think this was really raised earlier when Grace brought up the case study about the 29-year-old female that seemed otherwise completely healthy. So the question is, there's some concern about one size fits all approach to addressing high cholesterol. So how do you talk with patients who may be otherwise healthy and not think they need to start a statin?
Yeah, as far as one size fitting all, I mean, every patient we see is absolutely an individual, and that's why when I started out talking about the guidelines are a starting point. But our work day to day is translating the evidence and the guidelines to when I shut that door. I mean, my world is focused on that one and only patient, and each and every heart makes a difference. So my focus is working with that patient to try to design an individual plan. But that individual plan hopefully will be based upon a high intensity statin and a high risk individual. But that doesn't mean that's the only plan. Sometimes we might start, for whatever reason, a lower dose and think about combination therapy or alternate approaches to care. I mean, the last thing we want to do is break that trust, because if we break the trust, we don't have that conversation anymore, and we miss the opportunity to help this individual and their family. The important point is it's finding a vulnerable patient and a vulnerable family. And I'll hand off here to Grace.
Thanks, Larry. We've talked today about a really important topic involving our hearts, and sometimes the words that we use when we're talking about evidence and guidelines and things like that are sometimes difficult to make that connection when we're trying to communicate the importance, and sometimes, with our colleagues who, might also not be totally on board with this. And so I thought maybe what we could do is, could we have the next slide, please? Close out with a poem, and it's called Hearts, and it's actually by a family doc who works at a health center here in Seattle. His name is Peter Pereira. So Larry, I'll start and then you can help me wrap it up, right? Okay. The day nurse fishes in my mother's forearm for a good IV site before letting the orderly gurney her back to surgery. Surprise how black her blood looks. We laugh about medieval humors, how hers should be more sanguine. The Valium pill is bitter and difficult for her to swallow, yet she wants the sleep it brings. She tells me again, 2 months of vague pains in her left breast, left arm, all her brothers with bypasses.
She remembers the day she set her teacup back upon its saucer, went to wake father from his nap, found him cold and pulseless. The ugly chaos of medics in the living room, jolting him with electricity, their arms plunging his lifeless chest. As she trails off mid-memory, I imagine the dye shooting through her coronaries, the arc of her life told in a jagged flesh of light, becoming indelible as a crack in a china cup. And, we are here for a learning lab, but this learning needs to connect back to the trusted hearts that we go to work for every day. And I'm very honored and gracious to serve as the executive director of the Million Hearts Initiative with the goal of preventing 1 million heart attacks, strokes, and cardiovascular events in our country. But this needs to start one heart at a time. And this was an awesome way to conclude, because this is really the work that we do every day. It's applying the evidence, it's applying the guidelines, but it's coming to work, trying to do the best we can for each and every person with whom we encounter in our clinics and beyond. So thank you very much, Grace, for sharing that poem, and hand it off to you, Meg, here to conclude.
Thank you so much, both of you. Heartfelt thanks for all of the questions you answered and for talking about how we share information in different ways. I think it's very important to reach people in those different emotional and informational ways. This is clearly informational. I do want everyone to have access to the NACHC resources we have on cholesterol. We're going to put the link in the chat, but you'll have access to these slides as well later. So we have several of those that I think can help both on the patient and provider side. And then there's some additional resources I have listed here that I think are really good. So some of them are on the Million Hearts website, some are Mayo Clinic, but I think you'll find that all of these that we're sharing here today can be helpful in initiating those conversations and helping your patients to understand the importance of statin therapy if they're high risk. So I'm going to